Right. So, chairpersons, friends, and colleagues, it's indeed a great honor and privilege for me to be here today. And I'll be talking about coronary artery calcification. But as you all know, coronary artery calcification is age and sex dependent. And when we are doing PCI in a heavily calcified coronary artery, it obviously increases the risk of procedural failure and complications. And we often worry whether we have difficulties in stent delivery. And during stent deployment, there's the question of underexpansion, asymmetric expansion, or malapposition. However, fortunately, we have some great tools and techniques that can help us tackle a calcified coronary artery. Like in this moderately calcified right coronary artery, what we did is we first took a buddy wire, and that buddy wire allowed us to take our balloons. We took NC balloons 1:1 ratio, and we did a thorough job of pre-dilatation. After pre-dilatation, we used anchor balloon technique where we used an extra balloon and that allowed us to take our stent easily. We positioned our stent, removed our anchor balloon and the wire, and we deployed our stent, did post-dilatation, and the final result was satisfactory. Simple technique, but effective. Now, this next case was a 60-year-old female who came to us with effort angina, ejection fraction 65%. Her left main and LAD were free of any significant disease. LCX was a small side vessel and totally occluded. Now, the right coronary artery was anomalous in origin and it had an aorto-ostial calcified lesion. And we struggled with our guide catheter to engage it. And we couldn't actually engage it properly. However, in that position, we were able to take 2 floppy wires, and then we did pre-dilatation with NC balloons, and we went up to very high pressure. But still, we were unable to crack the calcium on the aorto-ostial lesion. So what we did now is we took a Wolverine cutting balloon, 2.5 by 10, and even though our guide catheter is almost floating, the balloon went very easily. We then inflated it. We made a good job of opening up the aorto-ostial calcified lesion. After that, it was fairly easy. We took our drug-eluting stent, which went very easily. We deployed it after positioning it properly. We did post-dilatation with a 3.5 NC balloon. And the final result was quite good. But sometimes, when you have heavily calcified coronary arteries, if you don't use a debulking device or a plug modification device, things can get a bit complicated and you end up using a lot of hardware. Like in this post-CABG patient, all his grafts were occluded and we were tackling this distal left main bifurcation lesion, which was heavily calcified. We wired the vessels and we ended up using a lot of hardware. We used a taper tip balloon, we used NC balloons, we used non-slip elements to do a thorough job of pre-dilatation. After this, we were able to take our IVUS catheter and we realized that there was still a significant amount of calcium in the ostia of the LCX. So what we did is, we took a cutting balloon now. And with that, a 3 by 10 cutting balloon, we did a good job of opening up the ostia of the LCX. After that, we were able to take our stents. We sequentially took a stent for the LCX and another stent from left vein to LCX, positioned our stents, deployed our stents, did post-dilatation, did proximal optimization. And after that, we thought that after rewiring the LAD, we would be able to take the stent for the LAD. We could not do that. So we again did pre-dilatation with a 3.5 by 10 NC balloon, went up to very high pressures. We did kissing with NC balloons. After this, we could successfully take our stent from left main to LAD. We deployed our stent, did final kissing, did report, and this was the final result. So quite a cumbersome and prolonged procedure what we got there in the end. So obviously, when it's a heavily calcified vessel, we've got great tools that can do plug modification for us, and we need to use them, like rotablator, orbital atherectomy, laser, lithotripsy, etc. And actually, in our center, we have a low threshold for using rotablation in heavily calcified lesions. So we usually would use a rotablator if the lesion can be crossed by the coronary wire, but cannot be crossed by the balloon. So it's a balloon uncrossable lesion. Or when we see that our balloon is not expanding properly, or we are unable to cross the lesion with our stent despite multiple predilatations, or if the iris gives us evidence that there is extensive calcification more than 270 degrees. In this severely calcified right coronary artery of this patient who was on dialysis, PCI was actually attempted in another center, but they could not open up the balloon and could not predilate the vessel. So this patient was sent to our center, and 2 weeks later, we decided from the outset, you can easily see the calcium angiographically, heavily calcified vessel. So we did rotablation. We did rotablation first with a 1.5 millimeter and then with a 1.75 millimeter burr. And we had to do rotablation through almost the entire length of the heavily calcified RCA. After that, we did pre-dilatation, and we did it sequentially with 2.75 and then 3 millimeter balloons. We then took our drug-eluting stents, positioned them, deployed them, and this was the final result. And I'm sure you'll agree with me that if we had not used the rotablator, we would not have got this kind of results. Now, this 77-year-old gentleman has a very long history. He underwent CABG in 2000, and he received the SVG graft to LAD and an SVG to ramus and PDA. A check angiogram was done in 2010. They found that the SVG to LAD was patent. However, the SVG to ramus and PDA were occluded. So at that time, in 2010, a cipher stent was deployed from left main to ramus. Now, 10 years down the road, in October of last year, he started having chest pain again, and he went to the same center where he had been earlier treated, and they found that the SVG to LAD was still patent. However, there was ISR in left main to ramus stent, the cipher stent. They attempted a PCI but failed. So this is how the vessels look. So his native LAD, native LCX and RC are totally occluded. And as you can see, there's significant ISR from left main to the ramus vessel. All the venous grafts are occluded except for the SVG to LAD. So in that center, they attempted to do PCI, but they could not open up the vessel properly. They decided to call it a day, and he was started with more medications, optimize the medical therapy. However, his situation did not improve, and we did this case actually last 2 weeks ago. So as you can see, this is how the vessel looks. And what we did is, from the very beginning, we decided we would need to do rotablation. We went with a 1.5 burr, and it was quite a struggle. After rotablation, this is how the vessel appeared. We did pre-dilatation with 3.5 by 6 NC balloon, went up to 20 atmospheric pressure. We then took a third generation drug-eluting stent, deployed it, did post-dilatation with the NC balloons, did proximal optimization, and this was the final result. Now, this is the last stories of an 82-year-old, very frail female patient with multiple comorbidities. And she was admitted in another hospital with unstable angina, and they had to do an angiogram there. And they found that she had severe triple vessel disease. The vessels were calcified, and considering her frailty and her age, the surgeons were reluctant to do surgery on her, and so she was transferred to our hospital for revascularization. And frailty is something that's very difficult to define and more difficult to treat. And so what we did for this frail elderly lady with multiple comorbidities is that we staged her procedure. So we first did the RCA, and only 5 days later did we decide to tackle that heavily calcified left side. And as you can see, it's even angiographically, the calcium is pretty much visible. So here we knew that this frail lady would not allow a very long procedure. We had to be as gentle as possible. So from the outset, we decided to do rotablation. We first tackled the LCX with a 1.25 per. After that, we went to the LAD. We tackled it with a 1.25 per as well. And we found that there is still a lot of calcium left. So we stepped up our burr and went to 1.5 millimeter burr. After pre-dilatation, we again here the IVUS played a vital role. Not only did it allow us to decide on our strategy, but also on what to do. So we knew from the IVUS that we would need to go for a double stent technique. And indeed, we went for a DK crush here. And the final result was quite satisfactory. So in conclusion, I would like to say that when we face a heavily calcified vessel and we can even see the calcium angiographically and it is balloon impossible, then we should opt for a device which will allow plug modification, and the choices are obviously rotablation, orbital atherectomy, or laser. Now, what if the balloon goes, but we cannot dilate the balloon? So it's a balloon non-dilatable lesion. Now, here, we should definitely go for imaging. And if the imaging shows that the calcium is less than 270 degrees, then we should strive further with balloons, go for an OPN balloon, and usually that will do the trick. However, if we see that the calcium is indeed less than 270, but if there is nodular calcium present, then we should go for rotational or orbital atherectomy. However, if the calcium is more than 270 degrees, then the choices are obviously rotational atherectomy, orbital atherectomy. For small size vessels, I think rotablator is safer. For larger size vessels, orbital atherectomy will be equally effective. For 360 degrees of calcium, or if it's a large size vessel and it's a narrow length of calcium, then obviously lithotripsy works very well. Once we've done plug modification, obviously we need to do proper job of pre-dilatation with 1:1 NC balloons, go up to high pressures. We then take our stent, deploy it from healthy to healthy segment, do post-dilatation. And here again, our IVUS plays a vital role in showing us that we have not left a malapose stent or a floating stent there. So when we, this would be, I think, the algorithm to tackle calcified vessels. And when we tackle such complex calcified vessels, the most important ingredient is the teamwork. And from the entire team of National Heart Foundation Hospital and Research Institute, I would like to say thank you for giving me this opportunity for presenting this case. Thank you.
Thank you, Fazila. Thank you. Thank you. I'm sure all of us, all of you agree. She is such a skilled operator, and she showed us such unbelievable cases from Bangladesh. And thank you for the excellent presentation. I just want to start off the question. Now that till the shockwave came in, for us, rotablate combination with Wolverine or cutting balloon was the way to treat calcified lesions. How does the IVL impact your practice today? Where do you recommend IVL to be used?
You're asking me?
Yeah, shockwave therapy.
Okay, so actually, the news is that in Bangladesh, shockwave has not yet arrived. So we're still doing the rotablator and the Wolverine thing, but we've heard that it's going to come pretty soon. So that's exciting. But from what I've heard, it's like 360 degrees catching. But I'm sure lots of you have experience about shock wave, and I would like to learn from you.
All of us use a lot. I think I would request Santoso to make a comment on that. Those of you who do not know Santoso, he is one of the best interventional cardiologists in Southeast Asia.
Thank you so much, Matthew, but you're my teacher. You're my and as well as Ashwa. If you could allow me, I want to give two comments. One is regarding imaging. In cases with severe calcification, imaging is of utmost importance, and this is usually done with either IFUS or OCT, and this is a must. And usually we use the scoring system, as mentioned also by Fazila. And if the score is, I don't want to elaborate this more in detail, but if the score is 3 or more, then we need to use rotational atherectomy or orbital atherectomy or any other devices like IVL. And then what is also important with imaging is that to see whether there is volume reduction by after doing ROTA or OAS, for example, by looking at the smooth or concave surface of the calcium, and also very important also the presence of cracks, because if we have these two, then we know that the vessel is already well prepared for stenting. So we need a very good platform, otherwise the result of stenting would not be appropriate. That's number one. And number two, there are so many algorithms for treating calcific lesions. But what is missing in all algorithms is two conditions. One is STEMI. In STEMI or acute coronary syndrome, STEMI and non-STEMI, approximately one-third to one-third of the patients, one-fourth to one-third of the patients with STEMI or non-STEMI has moderate to severe calcification. And we know the use of ROTA and also OAS in this situation is contraindicated. So in this kind of situation, we need to use a high pressure balloon or IVL as suggested by Matthew. And the other situation, which is never mentioned in all algorithms, is in-stent restenosis with calcification. And the calcium may present outside the stent, because if you implant the stent with the vessel not appropriately prepared and still a lot of calcification, the patient will, the lesion will ultimately go into in-stent restenosis. And the second is the presence of calcium inside the stent. And this is because of neointimal proliferation, new atherosclerosis, and new calcium deposition there. And the predisposing factor is the same, like, for example, aging and also the presence of calcium, and also chronic kidney disease. So this kind of situation is very difficult to treat. Usually, we need to use a super high pressure balloon like OPN, where we can apply a pressure of up to 35 to 40, or IVL. But from time to time, we can still use ROTA and or OAS. The trick is, with ROTA and OAS, there is always a risk that it may interact with the stent and it may have problem. For example, burst stall with ROTA or also with the diamond pack. So to avoid this, if we use ROTA, we need to use only high pressure at high speed, like 180, 190, because with the high speed, the burr will stay inside, very stable. With low pressure, low speed, like for example, 140, the burr will tend to move uncontrollable. And with, on the contrary, if we use OAS, orbital atherectomy, we need to use low speed and not the high speed, but low speed. Because with low speed, the burr will spin in a small orbit. So it will not damage the stent. That's my short comment. Too long.
Thank you so much.